The glycogen storage diseases are an enigma to a lot of people. They're very difficult to keep in line and to understand them, and they can be difficult to remember for a lot of people. And so I think one of the easier ways to remember the glycogen storage diseases is by understanding glycogen metabolism first, and then working from there to remember the enzymes or the points at which this process of glycogen metabolism is disordered, and then it makes a lot more sense from there if you can understand this. So let's apply basic sciences and talk about glycogen storage diseases. We'll start with a vignette. A 3-month-old baby boy presents to your clinic with his mother because she's concerned about his weight. She also says that he doesn't seem to be developing like her other children did by this point. You note that the baby currently weighs 11 pounds and is 23 inches long, which puts him in the single-digit percentiles. Though he is alert and arousable, he lays flat on the exam table and does not reach out at objects placed in front of him, but he does track them with his eyes. Physical exam reveals a hypotonic infant and no apparent distress. When you go to lift him, he doesn't maintain his head and neck, and it must be supported with your hand. Faces are unremarkable. His tongue appears large for his mouth. Liver is easily palpable at 4 centimeters beneath the costal margin. A soft systolic murmur can be appreciated. Remainder of physical exam is unremarkable. Neonatal course is unremarkable. He has not had any infections or illnesses that the mother is aware of. So our clinical impression here is that we have an infant that is failing to thrive. Why is he failing to thrive? Well, he's small. He's in the single-digit percentile, so he's not growing properly. He's also not meeting his milestones. At 3 months of age, baby should be reaching out to grasp things, should be moving his legs and kicking at things. He's not doing that. Now, one of the reasons he might not be grasping things is that he doesn't see it, and so you always want to rule visual problems out. Well, he tracks the objects with his eye, so he can clearly see them, but he's not reaching out to grab them, and that's not normal. We also realize that this baby is grossly hypotonic. When you go to lift him up, he should support his head and neck to some degree, and he has this head lag, where his head is just kind of falling backwards when you go to lift him up. And so that's concerning. That points to hypotonia. We also see this macroglossia, which is interesting, and then also very concerning is the hepatomegaly. Now, the soft systolic murmur may or may not be important, but given that he's got all these other problems, we do want to look into it. Systolic murmurs are not uncommon in babies, but because of all these other problems, we want to look into it. So what are we going to do here? We'll get a CBC and BMP, or basic labs, liver function test because of the hepatomegaly, creatine kinase looking for muscle issues because of the hypotonia, and to look at the heart, we'll get a chest x-ray and an echocardiogram. And you may do additional tests, but these are the basics that you'll want to start with. And we find that the CBC, BMP, and liver function tests are all within normal limits. The creatine kinase is dramatically elevated at 3,150 international units per liter. And then the chest x-ray shows cardiomegaly, and the echo shows thickened ventricles. So we have muscle issues, some kind of muscle breakdown going on, as well as heart issues. We have an enlarged heart. And when you put this all together, this points to a glycogen storage disease known as Pompe's disease. Now, you'll need to do additional tests in order to diagnose Pompe's disease. Traditionally, we do a muscle biopsy. However, now we do sort of more molecular biological testing. We can do a genetic test to diagnose Pompe's disease. Okay, so we'll briefly review glycogen synthesis and degradation, and then we'll talk about some of these glycogen storage diseases. I want to focus on von Gierke's, which I already kind of talked about in the glycolysis section, Pompe's disease, McArdle's, and hers. I talked about Tarui's also in the glycolysis section if you want to go back to that. So glycogenesis, just briefly reviewing here. So we start, why do we do glycogenesis? What's the point of forming glycogen? It's because we have all this glucose coming in. We don't always need it right away. And so your body stores some of this glucose so that when you're fasting, for instance, as we're going to see with glycogenolysis, you can make glucose. It's one of the most efficient means of gluconeogenesis. There's other ways we can form glucose, but using glycogen is one of the most efficient ways. So we take glucose and we change it. We want to change it to UDP glucose because that's going to be our molecule that directly goes into glycogen. So our means of doing this is by forming glucose 6-phosphate and then converting that into glucose 1-phosphate. And this is done by enzymes that are used in glycolysis and gluconeogenesis. And then we remove that phosphate from the oxygen off the first carbon, and we replace it with UDP. And the way we do that is by taking UTP, pulling off 1-phosphate from that, pulling off the phosphate from G1P, and then adding on the UDP. Okay, and where do these carbon numbers come from? You'll want to know that because when we're talking about these bonds, it becomes important. So if you remember back to organic chemistry, the first carbon is going to be the one that is linked to the highest number of higher atomic numbers. And so this carbon here is bonded to 2 oxygens, so that's going to be our first carbon. And then we just work clockwise from there. 2, 3, 4, 5, and then 6 up here. Okay, so we have a UDP off the oxygen off of the first carbon. And then this UDP glucose is going to react with a glycogen precursor called glycogen. And so we have 1 glucose off the glycogen. And then glycogen synthase is going to just add these glucoses onto our original glucose. And it does that with UDP glucose. The UDP will come off because you're reacting hydroxyl groups. You're going to form water. And then we have another glucose added on to this glycogen precursor. And this forms an alpha-1,4 bond. Why is it called an alpha-1,4 bond? Well, just think of it. We have carbon 1 here, and then our oxygen, and then this carbon here is carbon 4. So carbon 1 from our non-reducing end, carbon 4 from the previous glucose, 1,4 bond. We continue doing this, we form a straight chain. Now, we don't want to just form straight chains to infinity. We want to form branches because when we form branches, it makes the glycogen more soluble, and it's just more efficient that way. It's easier to store. And so the way that we form branches is through this enzyme called branching enzyme, which is also known as glucosyl 4,6-transferase, but branching enzyme is what you'll want to remember. And this branching enzyme, what it does is it takes a bite off of this linear chain, and it takes 6 or 7 glucoses off of it. And what it's going to do is it's going to form a 1,6 bond. So you're going to form a bond with oxygen in the middle between a first carbon, which is right up here, and the 6th carbon, which is this one. If you're looking at glucose, it's this carbon right here. And you release water from that, and you're basically just doing the exact same things when you form the 1,4 bond, but you're forming a 1,6 bond. Okay, and that makes a branch. This is not going to be linear because these glucoses are going to be further apart because of the electrons from these hydroxyl groups. Okay, so you form a branch, and then you just continue adding on glucoses, adding with the glycogen synthase, forming more branches with the branching enzyme, and you're left with this very arborized molecule, which is how we have glycogen in our body. Okay, now let's say by the way, glycogen synthase, it is regulated. So what regulates it? You don't need to memorize this because it makes perfect sense. So when would your body want to form glycogen? Well, when you're pulling in glucose, when you have enough glucose in your blood and you're pulling in glucose into your cells will then store that. And so when you have enough glucose in your blood, what does your body secrete? It secretes insulin. Insulin is going to upregulate glycogen synthase. When would you not want to form glycogen? When you want to use glucose rather than storing it. So when you want to use glucose, what's your cell going to be like? It's going to be energy deprived, because if you want to use glucose, it's probably because you don't have enough ATP. And so if you don't have enough ATP, what's going to be sitting around? Simple, AMP. ATP that's been utilized, and now you're left with just AMP with those 2 phosphates off of it. So AMP will downregulate glycogen synthase. And there's other things, and this is indirect, and there's other things that regulate glycogen synthase, but these are the ones you'll want to be aware of for the test. Okay, glycogenolysis is a different process. So glycogenolysis is how we pull glucose off of glycogen. We're degrading glycogen so we can get that glucose and put it into the bloodstream. Like I said, there's many ways that you can form glucose. Glycogenolysis is just one of them, but it's a very efficient way because we're directly making glucose rather than converting other things into it. So we take this glycogen, and an enzyme called glycogen phosphorylase is going to add a phosphate group on to the oxygen of the first carbon of the terminal glucose. This is our terminal glucose, also known as the non-reducing end. And we add a phosphate onto this oxygen here, and that's going to pull this glucose off of the glycogen. And now we have glycogen with one less glucose on it. And that's going to form a glucose 1-phosphate because the phosphate is coming off the oxygen on the first glucose, or on the first carbon. And so we have glucose 1-phosphate, and that's easily converted back to glucose through our gluconeogenesis enzymes. Glycogen phosphorylase is going to be upregulated when we want to get glucose into the blood. If you have a low level of glucose in your blood, what does your body secrete? It secretes glucagon. Glucagon will upregulate glycogen phosphorylase. AMP will upregulate glycogen phosphorylase because this is an enzyme. AMP kinase is an enzyme that forms when your body is deprived of energy, when your cells are deprived of energy. And then epinephrine sort of does the same thing as glucagon, but strictly within the muscles, primarily within the muscles. Glucose 6-phosphate will downregulate glycogen phosphorylase because if we have glucose 6-phosphate, it's a sign that we're already degrading glycogen, and so this is just sort of a negative feedback mechanism. Okay, now glycogen phosphorylase will cleave alpha-1,4 bonds, but what about the alpha-1,6 bonds? For that, we have what's called a debranching enzyme. So with glycogen phosphorylase, we can pull glucoses off linear chains, but we need a way of pulling off these branches. And so the branches, remember, are linear chains in a branch, and we can use glycogen phosphorylase to get glucoses off of that, but glycogen phosphorylase does not work for the last 4 glucoses of a branch. So how does this debranching enzyme work? Well, the very first step is to take the last 3 glucoses off the branch and put it on to the straight chain. Okay, and so we do that. That's called glucosyl transferase activity of the debranching enzyme. So we take those last 3, put it onto our straight chain, and now we're left with one glucose with a 1,6 bond. And so we just have that little stump of that former branch. That 1,6 bond can only be broken with debranching enzyme, not glycogen phosphorylase. And that's called the glucosidase activity of the debranching enzyme. It pulls that glucose off, and now we're just left with the straight chain, and your cell can continue breaking that down with glycogen phosphorylase. Okay? All right, any questions about this, please leave me a note below. So we're going to talk about these 7 diseases, but primarily we're going to talk about von Gierke's, Pompe's, McArdle's, and hers. Now, on the test, you may hear glycogen storage disease type 5 or glycogen storage disease type 1, or you may hear McArdle's disease or von Gierke's disease. You'll want to know which type goes to which name because they could give you either. And so the way I remember this, it's very dirty, it's very licentious, but here it is. Viagra pills cause a massive hard-on. VPCAMH, 1 through 6. And then you'll just have to remember Tarui's is at the end. Okay, so you'll also want to remember the enzyme, especially if you're taking step 1. You'll want to remember the enzyme that's associated with each of these. And when we talk about the symptoms to the disease, the enzyme will kind of make sense in how these relate to one another. Okay? So let's start with von Gierke's. I already talked about this in the glycolysis section, so I'm only going to briefly talk about this here. Von Gierke's can be characterized into 3 different types. Type 1A and 1B, though, are the most common. Type 1A can be characterized as it is a glucose 6-phosphatase defect, or just a mutation of the G6-phosphatase gene. And so this is a deficiency of the enzyme glucose 6-phosphatase. And that's responsible for the conversion of G6P to glucose. And that's a very important step because all of the pathways of gluconeogenesis, including glycogenolysis, all converge on glucose 6-phosphate. And if you can't convert glucose 6-phosphate to glucose, all of those ways that you can form glucose from other things, it's not going to work. And so your body has absolutely no way of forming glucose other than getting glucose through your gut. And so when you're fasting, for most of us it's fine because we can break down glycogen, we can do fatty acid metabolism, we can form glucose in many different ways. But for these people, they can only maintain their blood glucose levels by absorbing glucose through their gut. And that's a big problem. Just as an aside, type 1b happens to be a problem with the translocase that transports glucose 6-phosphate across the microsomal membrane, and so it's a slightly different disorder. They will be they will have the hypoglycemia issues because they can't get the glucose out of it, but they're also going to have problems with their white blood cells for reasons that are way out of the scope of this talk. So they will also, in addition to all of this stuff, they will also have a minor immunodeficiency. Okay, so von Gierke's is characterized by severe episodes of hypoglycemia because they can't do gluconeogenesis, and that's going to occur when they're fasting. As long as they're eating, they're totally fine. But once they start fasting, their blood glucose level is going to just keep dropping and dropping and dropping. Regardless of the fact that they're making glucagon, they have no way of doing anything with that glucagon signal. So how do you point out von Gierke's? Well, first of all, one of the unique things compared to the other glycogen storage diseases is that they have a doll-like facies. Okay? You'll just have to remember that. It has to do with the genetic defect, has nothing to do with the glycogen storage issues. They'll also, in addition to having a hepatomegaly, which is common among the glycogen storage diseases, they'll also have a renomegaly. Why? Because glucose 6-phosphatase it exists not only in the liver but also in the kidneys. So they'll be continuing to form glycogen in the kidneys as well, and their kidneys will become enlarged. What's this nausea, vomiting, weakness, and seizures? This is how they can present acutely. Okay, parents usually aren't going to bring their kids in because their face looks a little funny. They'll bring their kids in though because they're having seizures and vomiting. These are all manifestations of hypoglycemia. So if you have type 1 diabetes and you don't take your insulin, your body doesn't form any energy from that. Very similar. And you get these symptoms of hypoglycemia even though you have glucose in your blood. Well, these patients, they can't form energy because they can't do anything with their they can't get glucose out into their blood, and so they can't form energy from that. They can't do glycolysis and all that stuff. So it's similar in that you can't do glycolysis and you can't make energy. So they get these similar symptoms of hypoglycemia, except they have a real hypoglycemia in comparison to diabetes. Okay, so these symptoms of hypoglycemia, nausea, vomiting, weakness, and seizures are ways that this can present. This is severe hypoglycemia. Chronically, they can have failure to thrive because they're not making enough energy, malabsorptive diarrhea, because this exists in the bowel lumen as well. Joint pain. Why do they have joint pain? Well, one of the major clinical laboratory manifestations of von Gierke's is a lactic acidosis. Why do they have a lactic acidosis? Because one of the functions of gluconeogenesis, which requires glucose 6-phosphatase, is to convert lactic acid from the blood in the liver. It converts lactic acid back into glucose through gluconeogenesis. Well, if you don't have glucose 6-phosphatase, you can't do gluconeogenesis. Therefore, you can't convert lactate into glucose. Lactic acid is going to accumulate in the blood. That causes a lactic acidosis. What's the only other way you can get rid of lactic acid? It's through your kidneys. And it just so happens that lactic acid and uric acid take the same route out of the kidneys. And so if you have all this lactic acid leaving the kidneys, the uric acid is going to get blocked out. And so you'll have a hyperuricemia. And that uric acid in the blood can form crystals. Those crystals can form in the kidneys, causing kidney stones. They can also go into the joint space. And what is that called? That's called gout. And so they get gout, causing joint pain, kidney stones, and then they can also get a pancreatitis. So this is your workup. You don't have to do all of these, just you can do some of these based on the symptoms, but this would be a great workup if you suspect a glycogen storage disease. The problem is with that, we're working backwards. We don't necessarily know based on the symptoms if this is a glycogen storage disease, so we might start out with only a few of these. Finger stick glucose always going to be important if a patient has symptoms of hypoglycemia. Anytime a patient is seizing, you always want to get a finger stick glucose because hypoglycemia is a common cause of seizures and it's a very easy to reverse problem. Just give them IV glucose. So you'll want to check that anytime a patient is seizing. So a CBC and BMP, just basic labs. Liver function test because of the hepatomegaly. Lipid panel, you may or may not include that. Uric acid, especially if there's joint pain or if you suspect lactic acidosis, because that might give you an idea of the cause. CPK, chest x-ray, lactic acid, urinalysis, lipase. Like I said, you may or may not do all of these, but this is a good workup if you suspect a glycogen storage disease. Okay, so the finger stick glucose will show you a hypoglycemia, which makes sense based on the mechanism of this disorder. CBC should be within normal limits. BMP can be all over the place. Remember that because they have glycogen accumulating in the kidneys, because they can form uric acid stones, they can get an acute renal failure. They can also develop a chronic kidney disease because of insults to the renal tubules. So you can have a wide variety of disturbances depending on where you're at with your kidneys. Liver function tests typically within normal limits. Lipid panel can show hypertriglyceridemia for a reason I'll demonstrate to you in a little bit. Uric acid elevated, CPK, this is not a problem with the muscles, it's a problem with the liver and the cells, so this will be within normal limits, unlike some of the other glycogen storage diseases. Chest x-ray will be normal, lactic acid will be elevated because of issues with gluconeogenesis. Urinalysis, again, depending on the degree of kidney disease, there's a wide variety of ways that this can show up. Lipase will be occasionally elevated depending on if there's signs of pancreatitis. Definitive diagnosis is going to be a glycogen storage disease panel, which applies to any glycogen storage disease. Anytime you suspect a glycogen storage disease, you can get molecular testing, and that will tell you directly what glycogen storage disease you have. And 1A, 1B, and 1C have all of these enzymes here. So you don't need to memorize that by any means. The treatment is frequent starch feeds. So either you can do nasal gastric administration of glucose, typically that's done for really young children, or you can do PO, uncooked cornstarch, dissolved in water every 4 hours. The important thing is here that they're not fasting, because that's really the problem. You also want to restrict fructose and galactose metabolism. Why do you want to do that? Because that is going to hit a roadblock. Ultimately, both of those molecules are going to get converted into glucose 6-phosphate, and you can't do anything with that in von Gierke's disease. Okay, so remember we have a defect in glucose 6-phosphatase. The reason that we get a hyperlipidemia is because the glucose 6-phosphate has no way of getting converted to glucose, so it's all going to go through glycolysis. And when it goes through glycolysis, ultimately you form pyruvate, and that extra pyruvate, because you have excess glucose 6-phosphate, it's going to overwhelm Krebs cycle, and so that pyruvate, the pyruvate is ultimately going to get converted to fatty acids and cholesterol via acetyl-CoA. It's acetyl-CoA that directly goes into Krebs cycle, but you get the picture. So you'll just form extra fatty acids, extra cholesterol, extra triglycerides, and that's going to lead to that hyperlipidemia. This is a normal liver histology. Note the cells here. You can see that there's a little bit of glycogen where you have these clear areas. But with von Gierke's disease, you have much, 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 much more. Okay, so just lots of glycogen. Here's very severe disease. Okay, Pompe's disease. This is a deficiency of the lysosomal alpha-1,4 glucosidase enzyme. Now, this is not what's breaking things down into glucose. Okay, I mean, it does do that, but it's not our primary way of forming glucose out of glycogen. So you're not going to have a problem with hypoglycemia here. What is this enzyme doing in the lysosomes and why do we have it? We don't really know. But what we do know is that we need to break down the glycogen that's in the lysosomes, otherwise these lysosomes are just going to expand and get huge. So the problem here is that glycogen accumulates in various cells throughout the body inside the lysosomes. And primarily, the tissue that's going to be affected is muscle, cardiac muscle, smooth muscle, skeletal muscle, heart, which of course is cardiac muscle, liver, and nerves. So this is primarily a disease of muscle, heart, liver, and nerves. The presentation typically is in infancy. So they're going to have poor weight gain because of lots of issues, but especially because of their heart issues and muscle issues. Failure to thrive, difficulty feeding. The difficulty feeding actually has to do with the problems with their nerves, and I'll return to that in a little bit. So poor weight gain, failure to thrive, difficulty feeding. Accumulation in muscle is going to lead to a hypotonia. And then a glossomegaly can develop because of accumulation in the muscle tissue of the tongue. Accumulation in the heart leads to signs of congestive heart failure because this is going to cause a hypertrophic cardiomyopathy because of all this stuff accumulating in the heart muscle. That can lead to a systolic murmur because the hypertrophic cardiomyopathy can lead to an outflow obstruction, which would lead to a similar murmur that you would get with aortic stenosis, for instance. Accumulation in the liver leads to a hepatomegaly, and then accumulation in the nerves can lead to depressed or absent reflexes, and the particular nerves that are affected are those bulbar cranial nerves, which are, in addition to other things, responsible for things like swallowing, and that's going to cause a difficulty feeding. They can also have gait abnormalities too, but typically this is going to present in infancy, so we're not really looking at gait. So here's our workup. We especially, because we have hypotonia, we want to get a creatine kinase. And what's it going to show us? Well, we don't really have much of a problem with glucose metabolism because this is only an issue in the lysosomes. Still, they may have a slightly low glucose, but typically the glucose will be normal. Basic labs will be normal. They may have elevated transaminases because of the accumulation of lysosomes in the hepatocytes. The lipid panel will typically be within normal limits. CPK will be very elevated. That's going to be your first tip off right there. And the chest x-ray will show cardiomegaly, and this is really the cardinal feature of Pompe's disease. Lactic acid will be within normal limits. We don't have a problem with gluconeogenesis here. And the the urinalysis may show elevated oligosaccharides. You might want to remember that. That's pretty low yield, though. So definitively, you get a glycogen storage disease panel, and this will show you a mutation to the GAA gene. Don't remember that. Don't need to remember that. Alternatively, you can get a muscle biopsy, and that is what you're going to see on USMLE Step 1. If you're taking that, they're going to show you a muscle biopsy. You'll want to know what that looks like. Currently, there's no cure, but what you can do is you can do a sort of a high-protein diet. You can also do enzyme replacement therapy. That's kind of a more recent innovation, but it's called L-glucosidase alpha. You can look that up. But it actually has shown some promise. Okay, so Pompe's disease is this GAA defect. Okay, so see this here. This is muscle tissue. We shouldn't have all these big glycogen granules here, and these are actually in lysosomes. Okay, I should have put a slide on here that showed normal muscle tissue. This is relatively low resolution. But you have these massive lysosomes forming in the muscle. So here you see it again. And these are just big lysosomes within the muscle. And you see more here. So some muscles are affected more than others, but big, big, big lysosomes. Okay, Cori's disease, I just want to briefly talk about. This is an issue with the debranching enzyme, which is necessary to fully break down glycogen. And this is going to result in accumulation of glucose 1,6-bisphosphate in the liver and muscles. Typically, this presents in infancy. So you can have poor weight gain, failure to thrive, difficulty feeding because of hypoglycemia. You can get seizures. Accumulation in the muscle can lead to hypotonia. Accumulation in the liver leads to hepatomegaly. Cori's disease, interestingly enough, tends to improve with age. So because of that, it tends to be underdiagnosed. This will be your workup. Hypertriglyceridemia is something that you will often see in Cori's disease for reasons that I do not understand, and I'm not sure anybody understands it. If you know why, please write below, because I wasn't able to find an explanation. So you get a glycogen storage disease panel, and you see a mutation of AGL. Okay. Andersen's disease, again, very, very rare. I think it's like 1 in several hundred thousand. So this is deficiency of branching enzyme. Now remember what branching enzyme does. It forms those alpha-1,6 bonds. Without that, all we can do is form straight glycogen, just linear glycogen. Problem with that is it's very poorly soluble. And so you'll get very abnormal glycogen, also known as, can be referred to somewhat errantly as amylopectin. It's not amylopectin, but it looks like it. And this is poorly soluble, and it draws in some fluid, and that can lead to dysfunction of the surrounding cells. Constitutionally, they can have poor weight gain because of the surrounding disease processes. It accumulates in the muscle, leading to a general hypotonia. They can get cardiomegaly from this. This, however, unlike Pompe's disease, is a dilated cardiomyopathy. They can get wasting and contractures. Accumulation in the liver leads to hepatomegaly. Unlike with type 1, with von Gierke's, this hepatomegaly and liver issues will lead to cirrhosis and liver failure. Okay, and with this liver failure, then they can develop other symptoms later on, things like portal hypertension, ascites, varices, and that ultimately is what leads to death in these patients. Okay. They tend to die before 5 years of age. So this will be your workup. You'll see abnormalities of the liver function tests because of nascent cirrhosis and liver failure. Glycogen storage disease panel for diagnosis. Okay, McArdle's disease you really want to be aware of. It's not terribly common, but it's one of those things that is just has certain characteristics, especially histopathologically. You just want to know it because the USMLE loves to test it. It's one of those classic disorders. And so USMLE loves this one for one reason or another. So McArdle's disease is very specific. It's a deficiency of a very specific enzyme. It is glycogen phosphorylase, which you have all over your body, but this is specifically glycogen phosphorylase in the muscle, myophosphorylase. And so you're not going to have liver issues with McArdle's disease. It's strictly muscle. And it's primarily, I assume, skeletal muscle because they don't have heart issues with McArdle's disease. So it's skeletal muscle issues. So they don't have glycogen phosphorylase in their muscle. What does glycogen phosphorylase do? It cleaves glucoses off of the straight chains of the glycogen, the alpha-1,4 linkages. And so for most of us, we do exercise. We have a little bit of glucose sitting in our muscle. We use that glucose, then we shift to glycogen metabolism. And we can just cleave off glucoses and use those glucoses to form ATP. These patients, they'll be able to exercise for a little while, maybe a minute or so, and then once they need to shift into glycogen metabolism, they're in trouble. They cannot form glucoses from glycogen, they can't make ATP, and so their muscles are going to fail. So they have an inability to obtain glucose from glycogen in muscles, and that's going to result in a characteristic exercise intolerance, where they can exercise for a little bit and suddenly their muscles just stop working because they can't continue forming ATP. Also, glycogen can accumulate in the muscle, and that can lead to issues with muscle breakdown. So the presentation, usually this presents in childhood when you start exercising more, start moving around more. Infants, not so much, because they're not doing a whole lot of strenuous activity, which would require glycogen. So usually presents in childhood. Constitutionally, exercise intolerance. Make sure you know. If you don't associate any other word with McArdle's disease, associate exercise intolerance with McArdle's disease. Now, this can look very similar to Tarui's disease, which we'll briefly talk about at the end here. But exercise intolerance is going to be the primary manifestation of McArdle's disease. And they get cramping because their muscles have no ATP, so they cramp up. They can have what's called a second wind phenomenon, and that's where they're exercising, their muscles kind of stop working as well as they should, but once they start shifting into using lipids and nucleotides and other things to form glucose, then now they can exercise again because they're not using glycogen here, they're taking other pathways of gluconeogenesis. So they can get a second wind phenomenon. Dark urine. Why dark urine? Well, if their muscles break down for whatever reason, they get myoglobin then spilled into their blood. That myoglobin comes out the kidneys, and that's going to cause it to look like blood in the urine. And so they get a very dark urine, sort of brownish colored urine. Because they're breaking down muscle, they can get rhabdomyolysis, and that can lead to acute renal failure because remember, myoglobin is nephrotoxic. So the workup, you may get any of these, but definitely CPK is going to be important because they have muscle issues. So you want to look at CPK. How are these going to come back? Glucose, totally fine. Remember that it's not the muscle that is responsible for keeping our glucose levels normal. It's the liver primarily that does that. So glucose should be normal. CBC will be normal. BMP, variable. Why variable? Because they can have acute renal failure. They can have rhabdomyolysis. Lots of different things that can go on kidney-wise. So their BMP can be disturbed. Liver function tests, not a problem with the liver. McArdle's starts with M. McArdle's is a disease of the muscle. Muscle starts with M. That's how you remember it compared to the other one we're going to talk about next. CBK will be elevated, especially after activity. Chest x-ray, normal. No issues with the heart. This is skeletal muscle. Lactic acid, important here. So they don't have a lactic acidosis. They have no problem with gluconeogenesis. But remember what lactic acid is formed, the reason it's formed. So when we're doing glycolysis, we form lactic acid because we want to continue doing glycolysis. We form pyruvate, but when in one of those intermediate steps, we are using we're using NAD and forming NADH. And we need to replenish our NAD, so we donate an electron to pyruvate and we form lactate. Lactate is just a normal thing that we produce during glycolysis. Well, these patients are not going to appropriately do glycolysis in their muscles because they cannot form enough glucose. So while most of us, when we exercise, we just keep forming lactate, for these patients, because they can't form glucose properly from glycogen, they're not going to make that lactic acid because they don't have the glucose to do glycolysis. And so they'll exercise, but because they can't do glycolysis, they're not forming lactate. And because they can't form lactate, when they do normal exercise, they are not going to have that elevated level of lactate that the rest of us would have. So lactic acid will not rise with normal activity, and that you probably want to be aware of. Okay, they can have elevated uric acid. Why can they have elevated uric acid? The reason they can have elevated uric acid is because when you're doing gluconeogenesis, For these patients, they're going to need to do it through other ways, not through glycogen metabolism in their muscle, because they can't do that. But there's other ways in the muscle that you can do gluconeogenesis, and one of those ways is by recycling purine nucleotides. And that can then go into gluconeogenesis to do ATP production. One of the byproducts of purine nucleotide recycling is uric acid. Okay, so that it can be mildly elevated for them. They're not going to have issues with gout or forming uric acid crystals, but if you've got a uric acid level after exercise, theoretically they can have elevated uric acid. Urinalysis will likely show myoglobinuria. If they have acute renal failure, though, you may see other things. But myoglobinuria is going to be the important one. Glycogen storage disease panel. For anybody you suspect a glycogen storage disease, here will show a PYGM mutation. That M stands for muscle. Okay, now you will want to, the treatment, just make sure these patients hydrate well and eat glucose, not complex carbohydrates, but glucose before activity. Because it's the glucose that's going to be the only thing that they can use in their muscle to make ATP until they take other pathways of gluconeogenesis besides using glycogen. Okay, this you want to know. If you're taking USMLE Step 1, you need to know your histopathology. Okay, so this is normal muscle. Okay, normal muscle, so we have our sarcolemma out here, our muscle fibers in here in the pink, and then our peripheral nuclei. With McArdle's disease, they get these blebs. They're called subsarcolemmal blebs. And what these blebs are is just stored glycogen. Glycogen they can't use. So they have this stored glycogen here. Okay, so blebs, subsarcolemmal blebs is McArdle's disease. You can also do what's called a glycogen stain. So glycogen stain is just staining glycogen. And notice that in these muscle fibers, you see some glycogen. The glycogen is in the dark purple. Okay, so you see some glycogen. If you do that with McArdle's disease, you're going to see lots of glycogen. Okay, all this dark purple stuff. Just way too much glycogen. They can't use it in their muscle. Okay, another thing you can do is a phosphorylase stain. Remember, McArdle's disease is a deficiency of muscle glycogen phosphorylase. So if you stain for that, in a normal person, you should see some level of phosphorylase. Now, the darker, the more phosphorylase. So you have more phosphorylase in certain strands than you do in others. But all of your muscle fibers have some degree of phosphorylase normally. What do you see in patients with McArdle's? Diddly squat. You don't see any phosphorylase at all. You don't. The only thing that's staining your muscles here is phosphorylase. You don't have any. You have no staining. You don't see anything. Okay, here's another view here. Here it's purple. But normally you have this sort of checkerboard-like appearance. Don't see anything with McArdle's disease. You have no phosphorylase. Now, depending on the mutation and stuff, you might have a limited amount of phosphorylase, so you might have a limited amount of stain, but for the most part, these patients are not going to stain properly. Very, very different. Okay, HERS disease. So remember, McArdle's disease starts with M, M for muscle. HERS disease starts with H, H for hepatic. This is the hepatic, the liver equivalent of McArdle's disease. It's the same enzyme, glycogen phosphorylase, but this is in the liver. So these patients are not going to have issues with their muscle. They're not going to have issues with exercise, but they are going to have issues with keeping their glucose levels up. Because remember, it is the liver where you form glucose when your glucose levels in your blood drops. The muscle is not responsible for keeping your glucose levels normal. It's the liver that does that. Now, there are different ways that you can form glucose through gluconeogenesis, but glycogen metabolism is one of the important ones. So they're going to have, their primary issues are going to be with keeping their blood glucose levels up. They're also going to have issues with retaining glycogen in their liver. So deficiency of liver glycogen phosphorylase, inability to obtain glucose from glycogen in the liver, which may result in a mild fasting hypoglycemia. Note mild. This is not like von Gierke's, where all of the pathways of gluconeogenesis are inhibited, including glycogenolysis. This is strictly a problem of glycogenolysis. So it's not going to be as bad as von Gierke's, but they will still have some level of hypoglycemia. The reason, despite the fact this is not very common, the reason that this is likely to come up on the test, and the reason I highlighted this, is because of the inheritance pattern. It's X-linked recessive. Hirsch's disease should really be called his disease, because Hirsch's disease is primarily a disorder of boys and men, because it's X-linked recessive. Like all X-linked recessive diseases, primarily shows up in men. So look for a family history. If a little boy has it, his mom is a carrier. If mom is a carrier, she probably has brothers or a father who is affected. So look for a family history of hypoglycemia. Presentation, there's very few specific signs. Poor weight gain from chronic mild hypoglycemia, failure to thrive, difficulty feeding. They may, if the hypoglycemia gets bad enough for whatever reason, if it does get bad enough, they may have issues with seizures and vomiting and all that stuff. But it typically does not get as bad as McArdle's disease. Accumulation in the liver can lead to hepatomegaly and also hyperlipidemia. Not exactly sure why it causes hyperlipidemia, but it can. Look for, very important, look for a family history of childhood issues with hypoglycemia, including poor weight gain and hepatomegaly. So your workup, what are you going to see? It's mostly going to look normal. You can have elevated transaminases because of issues with the liver. You may hypertriglyceridemia will be the major lab finding. And I'm not sure why you can get hypertriglyceridemia with Hirsch's disease. I know why you get it in von Gierke's, but if you know why hypertriglyceridemia shows up in Hirsch's, please write me a note below because I want to know. Okay, glycogen storage disease panel, done for any time you suspect glycogen storage disease, will show a PYGL mutation. And I think that just stands for phosphorylase glycogen liver. Treatment, similar to von Gierke's, in that you're just giving starch feeds to prevent hypoglycemia because you can't break down glycogen in the liver, difficult to maintain your blood glucose level, so we give starch feeds. Starch breaks down to glucose, and then it's absorbed through your gut. Now, the reason, again, it's not as severe as von Gierke's is because they can take other pathways of gluconeogenesis. So they can use fructose, they can use galactose. Can't do it in von Gierke's because the problem is that final step, glucose 6-phosphatase. Hirsch's disease, they don't have a problem with G6-phosphatase. They can use fructose, they can use galactose. And so you don't have to, unlike in von Gierke's, you don't have to restrict fructose and galactose. They can use that in Hirsch's disease. Okay, and I should add, Hirsch's disease tends to improve with age. So this is not as severe of a problem. It's not as poor of a prognosis as von Gierke's. So we'll end with Tarui's disease, glycogen storage disease type 7. Now, Tarui's disease I already sort of treated in our disorders of glycolysis section, and the reason it's a disorder of glycolysis is because it affects an enzyme of glycolysis. This is very similar to something we already talked about before. Tarui's disease causes exercise intolerance, the primary symptom of Tarui's disease. What is that similar to? It's similar to McArdle's disease, and the mechanism is somewhat similar. With McArdle's disease, they don't have glycogen phosphorylase in their muscle, so they can't form glucose from glycogen. That's our major way of gluconeogenesis in the muscle. They get exercise intolerance because they can't make ATP. Don't have glucose, can't do glycolysis, can't form ATP in the muscle. Tarui's disease, their deficiency is muscle phosphofructokinase. Well, what is phosphofructokinase? It's one of our enzymes of glycolysis. It's before you start forming ATP. So if you don't have phosphofructokinase in your muscle, can't form ATP in your muscle, you're going to get exercise intolerance. So you see the similarities here. The big difference is, whereas in McArdle's, that enzyme was very specific to the muscle. You can't do glycolysis in the muscle. With Tarui's disease, it just so happens that that muscle phosphofructokinase is also expressed in another place, one other place, and that is the erythrocytes. If the erythrocytes lack phosphofructokinase, the erythrocytes are not going to be able to make ATP like they should. If the erythrocytes can't make ATP like they should, they can't maintain their membrane stability. They cannot maintain because you need ATP to power that sodium-potassium ATPase on the membrane. They're going to have a hard time keeping their cytosol normal. They're going to have an efflux of potassium out of their cells, and those cells are going to shrivel up and die, and that's going to cause a hemolysis. So they can have, with Tarui's disease, in addition to that exercise intolerance, they can have a hemolytic anemia, and that is not seen in McArdle's disease. So exercise intolerance plus hemolytic anemia. Tarui's disease is quite rare, certainly not as common as McArdle's disease, but I can see it, get one of those 99th percentile questions where they give you a disease, it looks like McArdle's, and they don't give you anything else other than it's McArdle's, and then they give you a hemolytic anemia on the labs, and then it's going to be Tarui's disease. Okay, so note that Tarui's disease is sort of an ancillary differential of McArdle's disease. It's also a glycogen storage disease, technically, in addition to being a disorder of glycolysis itself. So get a glycogen storage disease panel. It's a mutation of phosphofructokinase. Okay, so these are the four I want you to remember. Just going over these. Von Gierke's disease, deficiency of G6 phosphatase. It's everywhere. Primarily, their major symptom is going to be hypoglycemia because every pathway of gluconeogenesis ends up in glucose 6-phosphate. If you can't convert that to glucose, you have no way of getting glucose into your blood other than through the gut. So they're going to have major fasting hypoglycemia. Hepatomegaly, glucose 6-phosphate accumulates in the liver, glycogen accumulates in the liver, so they'll get major hepatomegaly. Hyperlipidemia, because all of that acetyl-CoA. You have excess acetyl-CoA because you have excess G6-phosphate, and all of that G6-phosphate needs to go somewhere. It's going to go into acetyl-CoA. Excess acetyl-CoA overwhelms Krebs cycle. It gets shunted into making fatty acids, making cholesterol, and so they will have a hyperlipidemia. They'll also have a lactic acidosis because their liver cannot convert lactate back into glucose because they lack glucose 6-phosphate. So lactic acidosis, hyperlipidemia, severe fasting hypoglycemia, hepatomegaly, von Gierke's disease. Pompe's disease, remember, Pompe's pumps, heart pumps. Pompe's pumps, heart pumps. Okay, disease of primarily of the heart. They're going to get a hypertrophic cardiomyopathy. Pompe's disease is a disease of muscle, okay, glycogen and the muscle. They will have some hepatomegaly, but primarily this is going to be heart muscle issues, skeletal muscle issues. So they'll have weakness and heart failure. McArdle's disease, skeletal muscle. Okay, this is muscle glycogen phosphorylase. They can't make ATP in their muscle as efficiently as they should. They'll have exercise intolerance. They'll also have rhabdomyolysis. Rhabdomyolysis causes myoglobin to get into the blood, and that myoglobin is then put into the kidneys where it is nephrotoxic, and that can cause renal failure. Hirsch's disease is liver glycogen phosphorylase, so they're going to have glycogen accumulating in their liver. They're not going to have any issues with their muscle like McArdle's because their muscle glycogen phosphorylase is fine, but they're going to have accumulation in the liver, so they're going to have hepatomegaly. They can't do gluconeogenesis as efficiently in their liver because they can't break down glycogen, so they'll have a mild hypoglycemia, not as bad as von Gierke's, because with Hirsch's disease you can do other avenues of gluconeogenesis, including using fructose, including using fatty acid metabolism, including other pathways. So with Hirsch's disease, it's a mild fasting hypoglycemia. They'll have also a hyperlipidemia, no muscle symptoms because this is liver glycogen phosphorylase. They can get poor growth because of chronic mild hypoglycemia. Okay. Any questions, write me a note below. Otherwise, I hope this was useful to you, and I will see you next time.